And before I officially kick us off, I want to highlight this wonderful document that our dear colleague from the MTN put together a couple of years ago, Claire Collins. This is called The Pleasure Principle and Evolution in Rectal Microbicide Research. If you haven't been keeping up with rectal microbicide research, it hasn't really been on your radar. This is a wonderful thing to check out and learn more about the whole history and where we are and why we are where we are today. So we'll drop that link in the chat as well. And it will also be in that resource document that I'm talking about. So now, without further ado, I want to get us going with our webinar. In a moment, I'm going to ask my wonderful co-moderator from thebody.com to introduce himself, Juan. And then we have three amazing speakers, Jonathan, Sharon, and Craig, who will all introduce themselves. And breaking up the action, I am super excited to be featuring today Eddie Wiley, otherwise known as Kelly Cassidy, live from Memphis, Tennessee, who will be breaking up the action with some much needed drag. So we will have a little drag interlude right after Sharon, and then Craig will bring us home for the rest of the webinar. I'm gonna actually stop sharing my screen now. Let me see here. And I'm going to invite my wonderful colleague, Juan Michael Porter, to say hello, introduce himself, and give us some opening comments.
Good morning, everyone. Thank you for coming. It's really a thrill to be here. I am the senior editor of thebody.com and The Body Pro, as well as the co-host of the Future of HIV Care podcast, which we just had Jonathan Baker on. You know, I'm the first person openly living with HIV to hold my position. And why that matters is, being a Black gay man, I am the face of this epidemic within the United States. And being able to speak about my lived experience, as well as experiences that many of my friends, peers, and colleagues go through on a day-to-day basis, has been, I think that I'm doing the work that we all want to do. And your being here means that you're also part of that work. You're trying to connect with people and figure out, how do we stop these things from happening? How do we help people have better anal health and safer experiences and pleasure while having anal sex? In my conversation with Jonathan, we talked about the fact that many people can and are having anal sex. And what I love about this panel is that so many people have devoted their lives to making sure that it can be done as safely as possible. And again, by being here, you're aware of the fact that you yourself may be having anal sex, your friends may be having it, and you want it to be the best experience possible. I remember being a teenager, way too young, having anal sex with no one to guide me. And I think that when you leave this webinar, you're going to have this idea of like, well, if anyone comes to me with questions, I'll be able to empower them so that they're able to get their freak on as they want to, whenever they want to, without feeling ashamed or as if they're in danger. Growing up in the 80s, it was always in the back of my mind that I'm going to die if I do this, but I'm still going to do it because it's what I felt I needed to do. And here's the thing, anal sex doesn't equal death. It just equals joy. But that's not the ideology that's been fed to us for so many years. A lot of that has to do with shame. And let's be clear, a lot of it has to do with the fact that many people are afraid of talking about butt sex. But since we're all doing it, I think that we should dive in, embrace, and have as much fun with it as possible. One of the things that we're going to be sharing at a certain point, a number of resources, is the conversation I had with Jonathan, a fantastic, full-on, whether you are a physician or just a lay person or just an enthusiast type of guide through all things anal, PrEP, and joy. Always, once again, led with the clear perspective that this is about pleasure. And I want to give a shout out to Dr. Sharon Brittler, who I was lucky enough to interview at CROI this past February, because I wish that Sharon had been the person to introduce anal sex to me, because I would have walked out of that experience feeling like, wow, there's nothing wrong with me. I'm just doing something that humans do. And with a clear commonsensical understanding that there's nothing wrong with me or anyone else who wants to enjoy this fantastic activity. So with that said, let's dive in. Jonathan.
Good morning.
Thank you
Thank you,
so much.
Juan.
And I want to jump in real quick before. I want to also give some love to Jonathan, also known as a rectal rock star. I met Jonathan years ago when he was just a baby working at the Microbicide Trials Network. I think you were maybe 20, because I was probably, if it was 10 years ago, I was 30, right? So I'm so excited to see you here and get us centered around anal sex and anal health, and help set the stage for our discussion on rectal microbicide research. We have over 300 people registered today, about 100 online right now. And Jonathan, can go ahead, share your screen and get us going. Thank you.
Thank you so much, both of you. It's such an honor. It's saying my screen share is disabled. So as we troubleshoot that, I first just want to thank AVAC and TCA for hosting this, Jim for putting it together, Jim and Juan for both being incredible co-hosts. And it is such an honor to be among this panel and also just this audience. I'm looking at the names in here, and this is really incredible. So without further ado, a quick intro on myself, because I want to talk about butts instead. I've been a PA for 13 years. I truly was a baby when I met Jim in Pittsburgh, where I worked in infectious diseases for 5 years, followed by where I am now in New York City in anal rectal surgery for the last 8 years. And because of that sort of split experience between infectious diseases and colorectal surgery, I've really created this niche for myself as the self-proclaimed rectal rock star and sort of expert on anal sex from both an ID side and an anatomical side. So just for full disclosure, I do participate in clinical research trials by pharma. None of them are actually in the HIV prevention space, and I don't receive any direct payment from any pharma. So I wanted to begin with one of my favorite quotes from the World Health Organization about what sexual health is and what it isn't. And so according to WHO, sexual health is a state of physical, emotional, mental, and social well-being in relation to sexuality. It is not merely the absence of disease, dysfunction, or infirmity. Right? And I want to bring it back to a quote from Juan at the very beginning. If I'm going to do this, I'm going to die, right? Thinking about anal sex in the 80s and in the 90s and in the 2000s, even for some people today, when we're thinking about sexual health, this concept of creating a space for sex that is safe, where people can enjoy it without thinking about death, that is sexual health. And so there's so many layers to this. The most important layer for me is pleasure. And so I'm going to begin with a cross-section of the human body, and I'll help orient you a bit. So this is, if we cut someone in half right down the middle, this is the rectum that we're looking into. The outside is the anus. And then this particular individual whose cross-section this is has a penis. And so when we're thinking about pleasure, there's actually so many opportunities. And I want to start with sort of regardless of gender, the anus has so many nerve endings in it. And the only other place that has more nerve endings in it than the anal opening is the genitals, right? So you have a place where you can just experience so much pleasure, but also so many other sensations, like an increased sensation of pain as well. But just the opening of the anus is really a pleasure zone. In people who have a penis and a prostate, the prostate often gets all of the credit for anal sex. And it kind of should, because the prostate really is a pleasure zone. And so the sensation of touching the prostate through the rectum during anal sex is extremely pleasurable. But there's even more to that picture. So the back part of the penis, the penile bulb, actually sits right at the opening of the rectum. And so in someone with a penis, we're sort of penetrating the perianus, the prostate, and the penis all at the same time. Now, if someone doesn't have a penis and has a clitoris, I think we've all heard that the clitoris is just the tip of the iceberg, and that is absolutely so true when it comes to anal sex, because there's the clitoral crux, or the legs of the clitoris, which actually wrap around the rectum. And so during anal sex, there's also stimulation of the clitoris. And so people with the clitoris often report a lot of enjoyment during anal sex, and often sort of a different sensation to the clitoris than with vaginal sex. And then finally, people who don't have a prostate, there's a little gland that sits just in the same place as the prostate called the Skene's gland. And while we don't necessarily fully understand the function of this gland or how much pleasure it causes, this has been called the G-spot in the literature. But there's even more to enjoying sex than that, right? So thinking about intimacy and connection, the joy and sensation and pleasure of pleasing partners, the visual stimulations that can occur during sex, the excitement, the risk, and especially with anal sex, something that has been so taboo for so long and hopefully will be less so, but there's some excitement in that. So many things to enjoy. So I could talk about anal sex for hours. We unfortunately have about 10 minutes for me to talk about it. So there was a question about best practices for sort of preparing for anal sex. And to save us all some time, I'll drop the link to this after I'm done speaking. The Queer Health Podcast is a podcast put together by queer healthcare professionals. And this was the first episode that got the most listens because it's a great topic. And so really all the information that you could want here to listen to at your own time. So it shouldn't surprise you that anal sex is really common. In the US, about 30% of people, regardless of sexual orientation or gender, report engaging in anal intercourse. And condom use is generally fairly low, around 25%. And often people think of condoms as contraception rather than as STI prevention. Worldwide, we're actually kind of right in the middle. And I know we have a worldwide audience here. These are all different studies that were done in different ways, some of them more rigorously than others, but you can see rates that vary from fairly low to over 50% of the population. And I just want to recognize that in some of these places, especially those with sodomy laws, which include some states in the United States, and those with criminalization of homosexuality, which is fortunately not the US right now, but other parts of the world, there's probably underreporting of anal sex in some of those places. So as we move from pleasure into disease prevention, which is a wonderful thing and is pleasurable in its own right, anal sex happens to be a very efficient way of transmitting HIV. So receptive anal sex in particular, you have all of these immune cells in the anal cell wall lining that are the very target cells for HIV. You also have some of those in the penis and in other genitals. And so receptive anal sex carries 17 times the risk of vaginal sex. And even insertive risk actually has more potential for HIV transmission than any type of vaginal sex. But there's something that we can do about that, and that is PrEP, or pre-exposure prophylaxis, the use of medications in people who are HIV negative to reduce the risk of HIV transmission. There's 3 medications available. The first 2, which became available in 2012 and 2019, are oral tenofovir and emtricitabine, fixed combination single daily pills. And the second that just became available about 2 years ago is an injectable cabotegravir every 2 months. All of these medications are extremely effective at reducing the risk of HIV transmission. And when we think about how effective they are, it's actually a national news story when PrEP fails. So the handful of times where someone's used PrEP consistently and there's been an HIV transmission, those actually make the national news because it's so rare. Even though people who are using PrEP are undoubtedly challenging situations where their partners have high viral loads and may not be in care or may have barriers to care, where their partners probably have some baseline resistance even to the drugs being used. So PrEP still works in these cases. The side effects are really quite minimal. For oral PrEP, less than 5% of people get GI side effects, typically within the first week or 2, and then that typically resolve in a week or 2. And I've never actually had to stop a patient because of those GI effects. Similarly, with the injection, the majority of people do get an injection site reaction, so some pain or swelling where the injection was. But again, I've never had to stop someone. In the clinical trials, less than 3% of people stopped because of that injection site reaction. In the US, the USPSTF put out a grade A guideline as a preventive service for PrEP, meaning that PrEP should be covered without any cost to the patient, including for the visit, the medication, and the labs. Now, this doesn't always happen, but for most people, it becomes accessible. And for those who don't have a third payer partner, who don't have insurance in the US, there are programs that are available. The CDC also put out these robust guidelines. And one of my favorite lines is all sexually active adults and adolescent patients should receive information about PrEP. And what I like to point out about this is it doesn't talk about gender, it doesn't talk about sexuality, it doesn't talk about relationship status or structure. Everyone who's sexually active should at a minimum be aware of PrEP. So along with that, the most recent CDC recommendations for PrEP use are pretty broad. So people engaging in anal or vaginal sex in the last 6 months and who have a sexual partner living with HIV, regardless of their viral load, a bacterial STI in the past 6 months, like gonorrhea, chlamydia, or syphilis, or a history of no or inconsistent condom use. And if we look at people who meet this criteria, there's over 1 million people in the US and probably 10 million people worldwide. But I also want to point out, again, the majority of these people are actually heterosexual identified. And I'll show you in a bit, but we're really not meeting these targets. The CDC also put out recommendations for people who inject drugs. So looking at not meeting this, UNAIDS put out a recommendation to try to get 10 million people worldwide on PrEP by 2025. So that's that little red dot in the top right corner of the screen. And you can see our progress to date is a little bit lacking. So we have quite a way to go to meet that goal. And then sort of dividing up the world into geographies and where we want to focus this. All the way to the right is Western and Central Europe and North America, which is where I'm located. I'll focus on that. You can see there's really a big disparity in between what the goal is and what we've accomplished. And you see that throughout different parts of the world, with Eastern and Southern Africa actually being kind of the closest, but still only a little less than halfway there. To finish up, and I'm going to spend a little bit of time on this slide because there's a lot of questions around this. There are so many potential barriers to PrEP. And one of the biggest, though it's decreasing since PrEP was approved, again, 10 years ago plus, is the lack of public awareness and public knowledge. I think more importantly is healthcare provider lack of awareness, knowledge, and especially comfort. And so lots of education going into that space, because if healthcare providers aren't able to do this, we're really the gatekeepers for these prescription medications. Barriers to healthcare, so important, especially when we think about the US states that haven't expanded Medicaid, that are preventing access to HIV services. And then where I really want to spend time is institutional healthcare, personal, and other stigma, and the sort of extreme of that, which is criminalization of sex work, homosexuality, sodomy, HIV, and others. So, you know, as we're seeing increased laws that are impacting sexual and gender minorities in any way that politicians can find possible, both in the US and nationally, you know, some of the worst criminalizations of homosexuality going into effect worldwide as well. This is really a major barrier to PrEP and a major barrier to all kinds of healthcare. When we're thinking about the people who have these intersecting identities, racial and ethnic minorities, gender minorities, people with low socioeconomic status, commercial sex workers, these are the people most likely to be impacted by HIV, least likely to have access to PrEP, and most likely to have barriers to healthcare. And so there's so many things that need to be affected to increase this access to PrEP and the rest of healthcare, including addressing institutionalized stigma, including laws, cultural competence among healthcare providers and the entire healthcare system and addressing those cost barriers. So as we're thinking about developing more HIV prevention strategies, I think it's really important that we're engaging the communities that are most likely to be impacted, least likely to access PrEP, by including formal and informal leaders in that development process. And in the healthcare in general, we know that patients do better when they have healthcare providers who look like them. We need to address medical mistrust, which is rampant throughout the US and very validated. You know, the healthcare system has been terrible to disenfranchise people and continues to be. So, you know, a lot of that medical mistrust is really well founded. And then finally, I think it's important if we're especially thinking about our trans folks who are using hormones and their primary goal is to be themselves and the hormones get them there, helping to educate people whether there's interactions with PrEP and hormones, which for the existing technologies, there are not interactions, so that they know that they can be safe to use their hormones and PrEP as well. And then the final barrier is individual users, personal barriers to PrEP formulation. So pills aren't for everyone, injections aren't for everyone. We know with contraception that people like to have multiple options available to them and use the one that works best for them, and that promotes adherence. And so thinking about PrEP in particular, injectable PrEP users are actually more likely to want to continue to use it than was reported in advance of using it. And we're seeing increased uptake of 211 PrEP. So thinking about this sort of at the time of sex formulations for PrEP, you know, something like a rectal administered medication might be really, really appropriate. And so with that, I thank you so much for your time. I look forward to hearing from Dr. Hendricks and Dr. Riddler, and most to hearing Kelly Cassidy perform for us. And I'll take a peek in the chat and try to respond to any questions in there as we go. Thank you.
Thank you. Jonathan, you know, I was going to hop on for this specific question from Kevin McManus. Could you define receptive penile vaginal sex with regards to this training? I would love to hear your response. Could you do that live?
Receptive penile vaginal sex. So this would be an individual whose genitals are external that they might call a penis, going into someone's genitals that are internal that they might call a vagina. In the case of this training, the big comparison I wanted to make there was, you know, the anal lining has so many immune cells that make it this target for HIV versus the vagina has immune cells, but not as abundantly. So there's a similar sort of transmission route, but a different amount of probability of HIV transmission. There's also more tearing of the anus during consensual anal sex than there is of the vagina during consensual vaginal sex. Does that answer the question?
I think so. And I think Jim answered the other question. So thank you so much, Jonathan. I want to say something that really stood out to me is that you're focusing more on serving people who need access as opposed to wondering what's wrong with them. Why aren't they getting these things? And what I take away from this is it's not to question people, it's to help them and to question yourself and think, how can I best serve the community that matters to me? Thank you again. And now I'm turning this over to Dr. Sharon Rittler. Many people know her as an assistant professor of medicine in the Division of Infectious Diseases and a research professor. I know her simply as that girl. Sharon is going to be speaking about NTN-039, a phase 1 open label multi-single arm 2-period study designated to evaluate the safety and PK of TAF and EBG administered rectally as an insert at 2 dose levels. And jumping off of what Jonathan was speaking about in terms of access, I'm so excited to hear about this because this is access for people with vaginal tissue and without vaginal tissue. Sharon, Dr. Rittler, please take it away.
Thank you, Juan. And I just want to say that so I had a bunch of people ask for interviews around the time of this presentation at a meeting in February of this year. And by far and away, I enjoyed our conversation, my conversation with Juan among over all the others. So this, we're going to take us a step back, I guess, or a step away from the overall view that Jonathan set this up beautifully. So we do have injectable cabotegravir and oral Truvada or Descovy, but we also know that a lot of people, there are definitely access problems, and there are also issues with choice, where some people would prefer really not to take a daily pill or have an injection. So we're still quite interested in identifying some additional options to have choice, similar to contraceptive choice, where people can make a decision about a long-acting or a short-acting option. So I presented these data at a meeting earlier this year. So this was a study conducted by the Microbicide Trials Network, and I'm happy to share these results. So what we're going to talk about today is called an insert, and this one is called the TAF elvitegravir insert. So what this is a small, but here, and have another picture later, it's a small bullet-shaped sort of tablet, and it's fast dissolving. It can't be called a tablet because it's not intended to be given orally, and so that's where this name insert comes from. And each of these inserts has 2 anti-HIV drugs in it, one of which is tenofovir, and the other is elvitegravir, which is an integrase inhibitor. And both of these drugs have been well developed, and they're safe and well tolerated when given daily by oral dosing. So this insert's been developed by Conrad, which is a nonprofit organization led by Gustavo Donsel, among others, and is very involved with contraceptive and microbicide research. And so far, so this study I'm going to describe is the first study where the insert was given or administered in the rectum. So before people ask too many questions about what else has been done, this is it. But prior to this study, there was some quite a lot of work done actually by Conrad. So in animal studies, the insert's been tested both in the vagina and in the rectum, and was shown to prevent infection with SHIV, which is sort of a simian or a monkey HIV. Also in an animal study using the insert rectally, it was observed that putting 2 inserts together was better than 1 insert for preventing infection, again, in this animal model, and these are very small studies. Also, there has been a safety and drug level study using a single dose of 1 insert for vaginal use that Conrad has completed, was ongoing at the time that our study was starting. So what about, do people like these things? So stepping back from the study I'm going to describe, there was a study led by Jose Bauermeister in the MTN that looked at acceptability. So do people actually, what do people think about these options that might become available for use for topical use for rectal microbicides? So here again, you can see the insert. They also included an enema or a douche and a suppository. And what this study was looking at trying to really understand what people would think with routine use of these options, of these products. So the participants were young, 18 to 35 years old, and were transgender men, transgender women, and cis MSM. There were over 200 participants in 5 countries, and it was a crossover design. So each participant used, and these were placebo products, so there was no medication. So people could be on PrEP, not be on PrEP, preferably actually be on PrEP, but each participant used each of these products for 4 weeks around the time of sex, exactly how we would intend them to be used if they were medicated products. And they just looked at what people liked and didn't like. And the sort of high level view is that high acceptability was reported by 72% of the participants for the insert, 66 for suppositories, and 73 for the enema. So no one liked everything, right? But most people thought that they would consider using or would like to use a product like this if it were available. So our study, back to the study at hand, was designed to look at the safety of the insert when administered rectally, and we wanted to look both at one insert and two inserts, thinking back about the study that was done in monkeys. And we wanted to look at the drug levels. So pharmacokinetics really is the science of looking at the drug levels and the kinetics of them. In other words, how they change over time. So we wanted to look at blood, rectal fluid, and rectal tissue. And again, there are two drugs involved here, both TAF, which is the tenofovir, and the elvitegravir. So I don't want to belabor the study design, except to just point out who was included and a sort of broad overview of what happened during the study. So the study population were healthy individuals who did not have HIV, who were at low risk of acquisition of HIV because they couldn't be on PrEP. So this was not a study for people who should be on PrEP because of their sexual activity. This was a study for people who were not on PrEP at the time. They were at least 18 years old, and we intended to enroll 20 participants. So each participant had a screening visit and then a baseline visit, and had samples taken of their blood and their tissues before they had any study medication. And then they had two sequences of visits, two series of visits, meaning that they came in, had the insert placed in the clinic by the clinic staff, one insert, came back daily for 3 days, and we collected blood and tissues on a somewhat complicated schedule. And then the same person, waited several weeks and then came back, and we did the whole thing over again with two inserts. We enrolled 23 people. This was happening at the time of the COVID epidemic. In fact, both sites had to shut down for a while during 2020. So we ended up with 21 who completed the first dosing visit because a couple people had moved away from the clinic sites, and 19 who had the second dosing visit. The median age was 34 years, and sex at birth was 17 male and 6 female. And you can see that it was a pretty diverse population. This was done at 2 sites in Pittsburgh and Birmingham, Alabama. So what about side effects? This thing is pretty well tolerated. So the insert, again, this is a very early stage study where we only had 2 doses given. So, we're really just trying to see, get our toe in the water and make sure that this is safe before we go forward with any additional studies. There were 17 adverse events. An adverse event can be anything from somebody having a cold, someone getting COVID, having, a bad stomach ache. But only one event was felt by the study and to be related to the product, and that was a little bit of redness around the anus in one participant. But otherwise, there were no side effects. The participants were asked some questions, and there were some more detailed questions, but I just wanted to show just a few questions. How easy or difficult was it to use the study product? And this is, of course, a little bit odd because the participant didn't use it, didn't insert it, but that's, it's still a useful question. And so they all thought it was easy or very easy. How did it feel? There were a couple participants who felt a little bit uncomfortable with the insert, 2 with the single insert and 1 with the 2 inserts. And there was one participant in each stage of the study that had reported some leakage after the insert was placed. So what about these drug levels? This is a whole lot of dots on a piece of paper, but I want to focus your attention on the bottom portion. So this is the rectal tissue, and this is the concentration on the left-hand side is the elvitegravir. And what you can see is that by 2 hours, virtually all the participants had, and this is with both 1 and 2 inserts, had high levels of L-bictegravir in the rectal tissues, which is where we want the drug to be in the tissue to prevent infection. And over here on the right-hand side is the tenofovir in the sort of pink colors. And you can see again that there are high levels of tenofovir in the tissues. And furthermore, that even out to 3 days, the majority of participants had pretty respectable levels of tenofovir in the tissue for up to 3 days. This is another type of tissue assay where we're looking at the active component, the active product of the tenofovir. And I just wanted to show this just to show that compared to giving Truvada by mouth, which is a study that Dr. Hendricks did a few years ago in the HPTN, where they administered Truvada on a observed basis. So people were for sure getting the tablets. And then they measured the drug levels in blood and tissue. And you can see that compared to these levels in the red lines, all of the tissues from the participants through 48 hours and the majority at 3 days still had higher concentrations in the rectal tissue compared to what you saw with oral dosing. That doesn't, it's not a direct comparison because it's a different study, right? We don't want to make that mistake to say this is absolute, but it's very promising to see this amount of active drug in the tissues. So another thing that we did is we exposed the tissues, not the participants, but the participants had biopsies taken of the rectal tissue before, and in the gray over here is before they received any study treatment. And then the darker circles are 1 insert and the lighter circles are 2 inserts. And what you can see here, this is HIV, this P24. So what we do is in the laboratories, we take these little tissues and we set them up and then basically try to infect them with HIV, again, in the lab. And so before any treatment at the baseline visit, all the tissues are pretty easy to infect with HIV. And then after, at 2 hours, 24 hours, 48 hours, and 72 hours, the tissues were relatively protected, quite significantly protected, actually, from the HIV infection. So this is just an attempt to see if the drug in the tissues is having an effect. So in summary, what we observed in this phase 1 study is that the administration of the 1 or 2 inserts was safe and well tolerated. There were high levels of both drugs detected in the rectal fluid and the rectal tissues. Compared to baseline, the tissues that were taken from the participants after dosing were able to suppress HIV infection for up to 3 days. And so the results of this study, plus those animal studies that I mentioned earlier, really support the evaluation of this insert for rectal use. And also, I didn't mention, because the topic of the day is rectal microbicides, but this product also has shown good safety and drug levels with vaginal use, and so could have a unique niche of being a product that could be used both vaginally and rectally, sort of a front door, back door product, and on demand. So the next steps for this this insert, there is a next phase rectal study where people will have more doses to again observe for safety and drug levels. And there's also a study that's, I think, going to actually start fairly soon, doing the same thing with vaginal use. In other words, have people using multiple doses and make sure that this thing looks as good as it does here. So I'm going to stop and just note that the study, again, was done at University of Alabama and the University of Pittsburgh, and a whole ton of people. It takes a village, starting with our study participants who came in despite COVID, honestly. Masks and gloves and the whole thing was happening. So we really appreciate all the efforts that our study participants put in. And I will stop and either take questions or look in the chat and see what I can help with.
Let's do some, thank you, first of all, Dr. Rittler, and let's actually do some of those questions, quick rapid fire style, since we are on a schedule. The first I'm going to read out is why TAF and not TDF or TDF-FTC?
Right, so hopefully Craig Hendricks will help me if I stumble on these things, but I think TAF gets into the tissues quickly and readily and out and does not, I won't say linger, but it tends to get out of the systemic circulation and everything quickly. And it is a, it's basically, they're both end up in the tissue as the same drug, tenofovir, diphosphate. So I think it's just an terrible. I think it's a choice that is based on the pharmacokinetics.
I recall one of the things you said to me in February is that you actually want it to go to the targeted area. And
Exactly.
I wonder if that has something to do with it as well.
Yes, yes.
Awesome, thank you. Another question was around language. Is the term healthy HIV uninfected appropriate with this construct to be used in the context of a less stigmatized infectious disease? And just quickly, I want to say that I know that language is evolving and that we are becoming more aware of how things are written in scientific information. And I wonder what your perspective is on this.
Yeah, it's a great question because that's actually a really difficult one. People living with HIV is easier. I guess people living without HIV is probably a better term, a little cumbersome, but I think that's, I would agree that that's probably a better term.
And I know for the body, our language standard that I've been putting in is on people who are seronegative. I'm going from the people first. But I mean, that's also, flexible according to one's needs.
Yeah, that's a good one. It's one that's been a little more, I would say in my own usage and writing, it's been a little bit more challenging. So I like these options.
Yes, options being the primary way. The next question is, does this insert also prevent HSV? I'll just stop there at HSV.
Yeah, so that's a great question that I'm not sure who asked it, but it possibly is someone who's been reading the literature or seeing some of these presentations. So in the it may. So tenofovir has some preventative activity against HIV. I mean HSV, human herpes simplex, and in the study that Conrad did in women with vaginal use of the insert, again, these are studies where you take fluid or tissue from the participant to the laboratory, not trying to, not giving the participant any diseases or infections, right? But they did find some protection against HSV. So we did not look for that in our study, but I think there's some potential, and Conrad will be exploring that further.
Another question is the consideration taken for those using this TAF-EVG insert who receive analingus? How and would the medication have an effect on the participants' partners?
I guess that's a good question. We know that the vaginal fluid, the rectal fluid, and vaginal fluid does have drug concentrations for up to 3 days, but these are quite, I don't think there would be considerable absorption to the partner, and these are very, very safe drugs. So I don't think it would be a clinically I don't think it would be a significant problem, but I can't say for sure that there wouldn't be some uptake by the partner.
Thank you. And I'm going to have to pass the mic now just to stay on time, but we will come back around to the issue of the word healthy in particular. Thank you so much, Dr. Grittler.
Okay, thanks.
Thank you so much, Sharon. That was fantastic. I saw that Kevin had your hand raised. If you want to do your question really quickly, we can still take your question.
Yeah, so my question was basically, is this suppository, so to speak, is this a is it necessary for the participant or the client to take it take 2 doses?
Do you mean, Kevin, before and after sex, or do you just mean two of the inserts at once?
Not 2 of the inserts, neither, actually. I mean, day 1, day 2, or day 1, day 3.
Right.
That's what I mean, is like, do I have to take, as a client, do I have to take day 1 insert, and then do I have to take day 3 insert for it to be effective within my system?
Right. So let me just clarify that, because it's a great question. This study was really the drugs were present in the tissues for 3 days after a single dose. So the dose was either 1 insert or 2 inserts at the same time. Your question, though, is I think that the ultimate answer is we don't know, and it may depend on also the frequency of sexual activity. In other words, just like the 2-1-1 PrEP thing, when you get to a certain point, you're pretty much taking it every day. And we really don't know that much about, I mean, this was everything that we know about rectal use of this product in humans, I've just shared with you. So, so we need to do more studies where people are using the dosing more frequently, and make sure that there's no problems with safety, or and to try to understand how frequently, if someone's having frequent sex, should they use this every day? Should they use it every 2 days? Or how would that work? And we simply don't know yet.
Thank you, Sharon and Kevin, for that question. And just one more, and recognizing that this is really early phase research, and real world understanding is we're a ways away from that in terms of the clinical development. But did you find in this study, Sharon, any impacts regarding douching, anal or vaginal, regarding drug levels in the tissue?
Right. So what we did in the study actually is have participants douche the night before the insert was administered. And that's mainly because it's helpful to have a douche or an enema before the tissue biopsies. Then we didn't douche on day 1 at the 24-hour visit, but we did on day 2 and 3. So I would say we don't know yet in people, and that's one of the things that needs to be figured out. I will say that they did look at it, or try to look at it, in some of the animal studies, and it doesn't seem to, the concern would be, do you wash all the medicine out, right? Is it a problem in that regard? And it didn't seem to be the case.
Okay. Thank you so much, Sharon, and thank you for answering so many questions rapid fire. You're a champ, much appreciated. I am going to move us along now, and really excited to be introducing Eddie Wiley, also known as Kelly Cassidy, who is a person, a multi-hyphenate, many hat wearing individual, a consultant with JSI, a podcaster, a longtime advocate, and a fierce drag queen. So I'm gonna show a quick, we're a little fancy here, a little intro from Eddie/Kelly. Right now I'm gonna show as a video, and then we're gonna set up, I'm handling the sound because I am a professional DJ. And then Kelly is going to do her numbers. So let me share my screen really quickly and show you this intro video.
Hello, 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 everyone. Yes, my name is Eddie Wiley, also known as Kelly Cassadine, and I'm your drag entertainer for today's session. I'm super excited to be performing because at the time we agreed upon the session, the drag community in Tennessee was facing such a large threat to our freedom, our self-expression, but thankfully, you know, we've overcome that and we became victorious over the bigotry. Okay, so I'm excited for the support. As Jim mentioned, not only am I a drag entertainer, I also am a consultant with Jon Snow Incorporated, also known as JSI. I also host a podcast with engaging Arkansas communities, and I'm an avid TikToker. You can follow me at Eddie W Live. So yes, I am excited to be performing for you today, and without further ado, here's Kelly Cassadine.
OMG. Can we please give some serious love to Kelly Cassadine, bringing Tina Turner back alive? It brings tears to my eyes. It was so sad when we heard Tina passed away. She's such an icon, and I'm so delighted that Eddie chose to embody her today, Eddie/Kelly. So please give Kelly some more love in the chat. Let's see some hearts. Thank you so much. Before I turn it back over to Juan to introduce our final speaker, I also want to just give some love to our final speaker, Craig Hendricks, who is a longtime champion of rectal microbicide research. We wouldn't have this field continuing without him. And I especially want to give him some love now. He is following up a very tough act. So Craig, your work is cut out for you following Kelly, AKA Tina. But without further ado, I'm going to turn it over to Juan to give a maybe more proper introduction, and we can't wait to hear from you. Thank you.
Ooh, I forgot I was on camera while I was watching, so I was probably making all kinds of faces, but on with the show. Dr. Craig W. Hendricks is the Wellcome Professor and Director of the Division of Clinical Pharmacology at Johns Hopkins University School of Medicine. Dr. Hendricks trained in infectious diseases and clinical pharmacology at Hopkins before spending 10 years as an Air Force physician and 23 years at Johns Hopkins. I think it's more than 23 at this point, but using an older bio. And today he is doing a quick recap of RM/VM research history plus rectal douche.
Juan, thanks so much for the introduction. I'm going to go ahead and share my slides and just be sure these are okay. Does that everybody see that? We good?
You look gorgeous, Craig.
All right, thanks, guys. And so again, Juan, thanks for the introduction, and Jim for the and I have to thank Jim for putting me at the end after that amazing show. It's a tough act to follow. So let me try to bring it home. I'm going to focus on sort of the next chapter. This is sort of beginning where Sharon talked about the insert and move to an even more specialized approach, which we have been calling behavioral congruence. These are my disclosures. Importantly, I founded a company to develop rectal microbicides. I have no fiduciary or financial roles, and Hopkins is now managing the existing conflict. We're going to talk a little bit about PrEP development history and where it fits into all of HIV treatment and prevention history. Then I'm going to talk primarily about 3 different options. We'll talk about lube as rectal microbicide as PrEP, and 2 different douches. One briefly, because there's just been one study, and a little bit more about one that's about to enter phase 2. And then we're going to take a quick look at the future, which I think has never been more exciting than it is today. There's a handful of classes of drugs. There are dozens of drugs that are used to treat HIV, and many of those have been explored for HIV prevention. But the fact is, some of these drugs, different drugs like soaps and binding agents, have been around for a very long time, and these act locally. And these were developed originally to affect HIV where it infects, in the female genital tract or in the rectum. I'm going to show you briefly now how this is all of HIV treatment history and development. Each of these colors is a different class of drugs, and these are drugs that are very commonly used now. The tenofovir and emtricitabine are in this category. This would be the cabotegravir, for example, representing its class. But the prevention drugs have come out of this, at least those drugs that have been developed by industry, not surprisingly. They did the treatment studies, much with the help of the NIH in many instances. And then these have been developed largely by the NIH and Gates and other organizations nationally, with the support somewhat of industry, developed these for PrEP. And now we have these two options: oral tenofovir emtricitabine and also cabotegravir, a long-acting injection. But the vaginal microbicide history goes way back before that. In fact, the beginning of treatment and prevention was really very much around the same time. Vaginal microbicide, probably 20 years ago, the rectal microbicide development began, and it tried to build on many of the lessons learned from the vaginal program to do a little bit better and learn more quickly as we move forward with rectal microbicides. And you've already seen this. This is the TAF L-bictegravir insert that Sharon talked about a little bit ago. I'm going to touch briefly on the idea of using tenofovir or other drugs in a lubricant. And I'll talk about Q-grifocin and tenofovir as potential for douches. Now, this is the entire history, as I best understand it, of development of rectal microbicides. I'm going to focus only on a few of these. And what you see here for many of these is that either because of adverse events, modest acceptability of the dosing formulation, or pharmacokinetics that Sharon did a nice job introducing, that the drug is only around for a brief period of time. So if these products were used, they could be used, but they'd have to have repeated dosing. Sort of like the oral, even with the 2-1-1 regimen, there needs to be repeated dosing. There isn't much sustained presence of the drug for a period of time. So there are limitations to a number of these, and we're sort of left with these four. Now, again, Sharon told you about the TAF L-bictegravir, which I think is extremely exciting. Very high degree of suppression of viral replication in the colon. I'm going to focus on just a couple of these as we go forward. Now, this whole idea of behavioral congruence, the idea is that we would medicate, that is, add an antiretroviral to products that are already very commonly used in the context of sex. We'll talk primarily about sexual lubricants and douches, but the idea is very similar to, although it's not in the setting of sex, adding fluoride to drinking water and toothpaste, putting vitamins A and D to fortify milk. So the idea is that we would add an antiretroviral to a lubricant or to a douche that are already used, and use the existing sexual or parasexual behaviors to kind of piggyback and add something to maintain the pleasure so that that's not changed, but also make it perhaps safer than it may already be. So let's focus on some of these. If we compare the opportunity to sort of put the drug all the way in, and this is the applicator you see on the far left, and to compare what happens if you try to get drug in using a lube compared to a douche as different formulations. In this study, we actually put a radio label in each of these products. We put a radio label in so we can see it with certain radiographic scans as it emits some radiation. And we want to look to see how much of the drug actually gets in. And if you look at the applicator, where you inject it all the way into the colon, so nearly 100%, 95% of this gets in. But compare that to what happens with the lube, where with the lube, here you see some fraction is actually inside the colon, but a substantial fraction is outside, where it's not going to do any good. So a lubricant is a very inefficient way of delivering drug. It doesn't mean it can't be used, but it does mean that the amount of drug in the lube needs to be at a higher concentration certainly than we had expected, and higher concentration than any of the products have been studied in humans so far. But I don't count this out yet. And then finally, the douche over here, you see that 60% of the dose is inside. And the fact is, almost all of the dose goes inside to start, but the nature of a douche is that you put it in and much of it comes out, along with the other stuff, which is why the douching is occurring in the first place. So it is less efficient than using an applicator, but both of these, the douche or the lube, would be behaviorally congruent. These are activities that are already occurring with a very high frequency in this setting. So let's look at the lube one more time. This study is MTN 033, which was, the paper was very recently published by a collaborator, by a colleague, a very close colleague of Sharon Riddler at the University of Pittsburgh, Ken Ho. The goal was to look at the feasibility of using a lubricant as a rectal microbicide. It used a different active ingredient, dapivirine, which is the active ingredient in the vaginal ring that's approved for use in a number of sub-Saharan African states for women, comparing applying gel as lube versus with an applicator. The bottom line results are that almost half of the drug got delivered into the colon, which is a better result than the study I just showed you. So somewhere between 10 and 50% of the drug will get in. And it gives us an idea of how much more drug we have to put in a gel. But we also want to be sure that the drug will last for a long period of time, so we don't have to redose frequently, which is what would have to happen if we were using dapivirine, because it didn't stay very long. The figure I'm showing here is just showing there's sort of a modest reduction. This is the same assay that Sharon showed you, where we treat first, then we take a biopsy, then we challenge the biopsy with HIV, and there's only a very modest change, and it doesn't last very long at all. So we need to make some improvements to take the idea of a lube as rectal microbicide forward. Now, the whole rationale for douching, and the two products that I'm going to show you are a couple here. First of all, a single agent. This is a single agent, not like the one Sharon told you, which has two active drugs, which provides additional strength for the microbicide. But a single agent has been proven efficacious in a number of studies, both for oral tenofovir and for cabotegravir and dapivirine. Those are all of those I've shown effective with a single agent. On demand, like the 211, for example, has proven efficacious. Topical dosing has proven efficacious when it's used. This has been true with the vaginal ring, which is topical, and also with tenofovir vaginal gel in those individuals, in those women that use it as prescribed. What's unproven here is the ability to actually fit a drug into a product that's already commonly used. It should work. We have some questionnaire type studies and some experiential studies with placebo products that make it look quite promising, but we got to figure this out actually in clinical studies. Now, the first of these I'm going to mention, and this is all I'm going to say about this because there's been one study, the first in human study for Q. griffithsin. Q. griffithsin is a modified algae protein. It prevents HIV, you can see in the figure, prevents HIV from binding to the CD4 cells. In challenge experiments with macaques, it protects them from a vaginal challenge. I'm not aware of the rectal challenge studies having been done. The vaginal gel has been tested. There's been phase 1 safety and pharmacokinetics of griffithsin, in addition to carrageenan, which also acts as a binding agent for HIV. And there was no safety signals. And there was no systemic absorption. One would not expect there to be any. And that's part of the idea of using the topical. So there's very little systemic drug around to cause side effects systemically. And there's also activity in cervicovaginal fluid in that vaginal study against both HIV and HPV. So the idea is that this may be useful as a multi-purpose prevention technology. There was one phase 1 study also for safety and PK with the rectal douche. It was a single dose. The colorectal safety was established. There was a modest duration of the presence of the Q. griffithsin in rectal fluid, and the antiviral activity in the rectal fluid was, antiviral activity using the similar assays to what we showed you before was somewhat modest. So perhaps some adjustments in dosing or formulation so that it lasts longer and has more of an antiviral effect. Now, the next thing I'm going to talk about until the end here is the tenofovir douche. There's been a number of studies that have been done. I think we've completed now 5 clinical studies. We are about to launch a phase 2 safety and acceptability study. I'll tell you more about that in a minute. The total phase 1 experience is about 36 individuals, about 102 total doses. The median number of doses, because most folks that douche don't douche just one time. So the median number of doses is 3, because we need to understand how this, be sure this fits well into the lives of how folks actually use these products. Safety, I think, is pretty well established. There were 5 in all of these doses. There were 5 adverse events that were attributed, which is if you do these studies, it's sort of difficult to attribute or not to the tenofovir douche, which may well have been could have been the douche itself, as many of these symptoms seem to be. They were all grade 1 and they were all reversible. There were no changes when we take biopsies and look at them under the microscope. There were no changes compared to baseline. High degree of acceptability, high degree of likelihood of future product use. Now, Sharon showed you the pharmacokinetic data, the concentration, which you see here on the y-axis versus time, hours after sex or after the dose on the x-axis. And I'm going to start by showing you data that we have put together using modeling and simulation from observed studies and then making some extrapolations from a couple of other studies. And what you see here, these are the concentrations of active tenofovir. That's the tenofovir diphosphate Sharon referred to. And this is with the oral 211 regimen if you start from scratch. And what you see is it rises gradually over some hours, and then it peaks somewhere around 72 hours, and then follows on for another week, and it gradually declines. If one is doing this 211 every single week, you start at this point every week and have this level of protection for 72 hours before it starts to fall only a little bit. Now, if I compare this to the tenofovir douche with a single douche, this is the concentration I get. In the very first hour, this is as soon as we've looked at this, and the concentrations start either 1.5 or 2.5 logs above the 211 as soon as we look at it, and then it peaks here over the first day, and then it gradually falls. Now, it does fall faster than this, but these two lines cross around 5 or 6 days. Now, with the 211, if you had sex again out here, you would dose again. And our recommendation probably will be that we would dose again on the 4th day, similar to the 211 regimen, if sex occurs again. So we have better protection. We'll have to see if this works as well. We haven't studied this yet in an efficacy study. If I give 3 douches that are all medicated, the concentrations are pretty much the same, because each time the dose goes in, most of it comes back out. It's not like you have an accumulated 3 total doses inside. Now, it's very important that whatever product we develop has to be compatible with sex. So sex does a couple of things. Well, it does many things, but in terms of drug delivery, insertive sex displaces, especially with vaginal sex. When a penis goes into a vagina, it's a much smaller space than the rectum, and any gel or fluid that's been medicated will be displaced and come out more easily from the vagina than the rectum. And it also, when semen is added, it may dilute the product, which will reduce the concentration somewhat. Also, one needs to have a product that works well in the context of both lubricants and douches. And the purpose here of this is, again, you've seen a scan like this before. This is the pelvis. This is product. This is a simulation for a tenofovir douche using a radio-labeled small molecule. And you can see here it's throughout the rectum, the sigmoid, and up into the descending colon. Now, if I simulate sex and radio-label the semen, and what I'm actually doing is using an HIV surrogate, it's all the way down in here. These are different radio labels, so I see them very distinctly from each other. But it's all here, but very well covered by this distribution. That's when you have the douche and then sex. What if I reverse the order? And this is not unusual, because in our own work, we've seen that at least 25% of the folks that douche with receptive anal sex, they might douche before, and 25% will also douche afterward. So if you douche after this is deposited, this is what it would look like. So here is the HIV surrogate in the rectum, the sigmoid, and the descending colon once I've added the douche. Now, if I have a medicated douche, everywhere I find viral surrogate, I have drug. This needs to be true, I think, for other products that might be administered rectally if they're going to be administered in the setting of douching. So let me move on from there. The other limitation we have, the other challenge to fit into people's lives is to have a formulation for the douche that is flexible because folks use different methods. Some may use enema bottles, some may use syringe bulbs, some may use hoses. So we've decided to formulate this, at least for this phase 2 study, as a sachet. And the sachet is something that's actually very small. It's hard to get this into, there you go. You can see this as my mustache. So it's only 3 inches and it has a very simple perforated hair. And then one can just pour it. And you probably can't even see the pouring here, but I'm just pouring out the powder as if I would do this into an enema bottle or a syringe bulb. We need to work more on how we would actually fit it into the hose, but we've been thinking about that and need to be working with some engineering colleagues. So the phase 2 study is called Rev Up. Its number is HPTN, HIV Prevention Trials Network 106, rectal versus oral use of on-demand PrEP. It's a phase 2 study. The objective is to compare weekly tenofovir douche, a single series of douches, however many the individual wants, where the first and the last douche in the sequence are medicated. And we're going to compare that to the oral 211, given that our best comparator is an on-demand regimen, but a systemic one, an orally dosed one. The outcomes are safety, acceptability, product preferences, and then there's a sub-study with a much smaller number with pharmacokinetics and the antiviral effect. And here you see a close-up picture, not my mustache example of this is just our training douche example. You can see here the perforation and the about 3 1/8 inch size. So we have on-demand PrEP, both with the tenofovir. So one after screening would enter the study. And in this group in green, they're on oral for 8 weeks. And then they cross over to get rectal for 8 weeks with a little washout in between. And the other half are randomized to get rectal for 8 weeks, a little bit of a washout, and then oral for 8 weeks. So this crossover allows us to look at sequence effects that might occur. So this is an important part of the clinical study design. So 2 months with weekly dosing for each method, 2-week washout in between, 150 total participants, men that have sex with men and transgender women. These are the sites, and I'm flashing this quickly, but if any of you might be interested, these are the sites. It's heavy on the East Coast. This is based on who actually applied to be in the study. And we have one West Coast site at UCLA. And this also includes University of Pittsburgh and Hopkins. Pittsburgh is Sharon's site. We have had community input from the very beginning. Jim Pickett, who I think you all know now, has been involved with what we call the DREAM program, this tenofovir douche program, from the very beginning. We had community input at FHI 360 from the very beginning of writing the protocol, and you can see all the different meetings we've had with larger, including global community leadership as we develop this protocol. And I've got a talk in a couple of months to get ready for the Hopkins site. We'll be talking to our community advisory board. This has been absolutely essential. So any of you that might have already been involved in this, thank you, thank you, thank you. So what does the rectal microbicide future look like? I think it's actually quite bright. Sharon talked about the tenofovir L-vitagravir fast-dissolving insert. It has possibilities as an MPT, vaginal and rectal use, which is a big advantage, potent and durable. The question is, what will douching and sex do to that? The tenofovir douche, I think it's behaviorally congruent. Maybe that's an advantage. Similar characteristics in terms of potentially an MPT for herpes simplex virus, potent and durable. Can we develop a vaginal formulation? That would be great to have a product that was also used that could be used to protect vaginal exposures. And then finally, the lube. I think we're much further away from that, but I haven't given up on it. The question is, who will fund any more studies? And I also think there's a potential to add in doxycycline, for example, or other antibacterial drugs so that we could even broaden the multi-purpose prevention technology to cover a range of bacterial sexually transmitted infections. So I think this is very bright. And possibly when you go to your CVS or Rite Aid or whatever, you might find on the enema shelf, over the counter even, there's Fleet, and then there is perhaps a Fleet Plus, which has tenofovir for cleaning and PrEP, in a bottle or in a sachet, depending on your preferences. So with that, I will end and turn it back over to Jim. Thank you.
Thank you, Craig. And if you want to stop sharing your screen, beautiful. We're going to keep you highlighted though here. Daddy Douche, not only the king of rectal microbicides, but also our douche daddy. How do you like that? Will you take that as an identification for you going forward?
As St. Paul said, I become all things to all men that I might win some, and in this case, save some. So happy to.
All right, and I have at least a couple people in the chat are agreeing with douche daddy, so I think that is your new moniker. So as I mentioned in the chat, we're going to prioritize any questions or comments that can come in live right now on camera. So please raise your hand if you want to ask a question or make a brief comment. Oh my goodness, here comes trouble. I see trouble. So we're going to start with Rita, and then we're going to go to Shakir.
Hi, everyone. Again, excellent presentations. I just kind of want to challenge everyone to think about this. We have some great things in the pipeline, great preventatives, great care. But again, the toolbox means nothing if we're not truly addressing the stigma, the barriers. That's something we really have to focus on. And again, it's not a one size fits all approach. What might be a barrier stigma for one will be something totally different. And, some great comments were made. I know Jonathan agreed, with even the healthcare providers. I've been working in the community and listening to things where the community has had to educate our healthcare providers on how to, prescribe PrEP, giving coverage options, that sort of thing. So I want to lay the gauntlet out to all of us while we're working with these magnificent new approaches. Daddy Douche and Rectal Rockstar and Dr. Riddler and all the great work that's being happened. We need to address the stigma and barriers and keep working. But thanks to everyone. Fantastic webinar.
Right on, Rectal Rita. Thank you for all those great comments. 1000% co-sign. Agree. And Shakir, what is your comments or question?
Yes. So I just was watching a Zoom with about the pharmacy and how pharmacies are going to be starting to work and to push out the PrEP. Is there any way that maybe they can assist with these trials? And how do we, as people who work in the agency, for the LGBTQ plus community, how do we promote more of these trials? Because if we don't know about them, we really can't get people out, but we know that we have people who would love to be a part of all these trials. So is there a resource place that we could go to find out about trials that are coming up or things that are in the works so we can make sure you have participants? Thank you.
Craig, would you like to take that question or start it? And I will note, Shakir, that Rita gave you some information in the QA. So you left that question in the QA, and Rita responded, but Craig may have something to add to that as well.
Yeah, I was just going to say, so there's two parts to that. One had to do with delivery in the pharmacy, and I think that's going to become a very important part of getting PrEP up to the anticipated, to the target levels where the coverage is nearly perfect. That's going to happen, especially for the injectable formulations. So that's one way to do that. And I think what you're going to see is there may be some regulatory limitations of that. So there needs to be some modification there at a fairly high level, but excuse me, I think it's quite doable. And I think what you'll see is more demonstration projects that are engaging pharmacies as places for delivery. I'll also say that I don't know that the douche is going to be available over the counter, but those are conversations that have already begun with regulatory agencies and are potential. I think they may begin behind the counter, might end up over the counter. And again, so pharmacies become very important in that. The issues are about HIV testing, because one doesn't want to start PrEP if it's HIV positive person. But we're already thinking about trying to work on ways to get around that as an issue. So pharmacies are a very important part for a couple of reasons. For our trials, the HIV Prevention Trials Network, HPTN, has a website. They list the studies. It's not an easy thing to look at as a volunteer, for example, but it is a place to start for at least, you know, some of these things, like the study that I mentioned. And I'm not terrific. Oh, there it is. Thank you, Rita, for having it there. So that is a good place to learn about kind of what's cooking there. And Jim, there's probably others that are very useful to be able to get people connected with trials. ClinTrials.gov is a very clunky way to learn about what's there, but there is sort of a participant-facing interface there that can be used to sort of see what's available in your area. So I would recommend some of those. Jim?
I would just jump in and say that one of our writers at the Body, Tim Murphy, does quite a lot of writing about trial research, which he participates in as well. And Shakir, for your question, you just helped me to realize we need to do an explainer on how to participate in a trial. And I will say about organizations, what they can do to help promote this or how we can reach those organizations is, if you know of an LGBTQ organization that you frequent, go to them and ask them like, hey, can we make this information available? Because I know I want to do it, which means other people want to do it also. And then that sort of like taps leadership into the understanding of this is something we can do and possibly likely should be doing.
Those are great comments, Juan, and I'm going to turn it back over to you for some final thoughts, but I'm going to give my final thoughts first regarding that and then just the webinar. You know, none of this happens without community engagement. This research does not move forward without community advocates and voices demanding this. So you all showing up here is one way to do that. Please talk to your local folks, your local organizations, your local planning bodies, the folks who are doing research in your settings, and ask them what they're doing in terms of rectal microbicide research and other kinds of prevention research. Rectal microbicides especially really need some help. We're facing this world where everything is longer acting implants, things that go in your body and never, you know, don't come out for a really long time. And not everyone wants that. And a rectal microbicide douche could be something that you use when you need it and you don't have in your body when you don't need it. But again, if this is going to move forward, it's not going to happen just with Craig and his team. It really requires community support, loud community support. It was hard to get this phase 2 pushed forward at the HPTN, HIV Prevention Trials Network, and to move to a phase 3 will be an even bigger hurdle. Those hurdles will be easier to jump with lots of community voices and engagement, and being part of the TCA, the Choice Agenda, is one way to do it. So I'm going to finish my rant by saying thank you so much all for showing up. I'm going to turn it over to Juan in a second. But thanks again for showing up today, for being here. You will be getting an email shortly with the slide, a link to the slides, a link to the recording, and a link to all the resources that we shared in the chat. And then also you can see what's happening in the future for the Choice Agenda. We hope to see you frequently on our webinars. We hope you'll be on our listserv and engage in this kind of conversation, not just once a month at a webinar, but every day. So thank you for that. And I'm going to give my friend and colleague, Juan, the last word for this webinar. Over to you, Juan.
Thank you, Jim. Just to quote Jonathan, anal sex is about pleasure and people are having it. We can actually address these issues when we talk about that without shaming and dive right in and say, okay, what can we do to help protect you from anything regarding pain or possible transmissions? And because the lining of the anus is different from a vagina, for instance, it's much easier to transmit different STIs. And here we have come up with all sorts of things that can stop that from happening. One of the things I love about Dr. Rittler's research is that she focuses on men and women and people with vaginal tissue and without vaginal tissue, so that we're not cutting out an entire population of people. And as Dr. Hendricks pointed out, when we have more options, it is easier for people to access. And the only way we're going to end this epidemic is by giving access to as many people as possible. So by being here, you're moving that mission forward. And I really advise all of you, especially medical providers who apparently have some of the lowest rates of voting, of any other career, to speak to your representatives, because quite often there are quacks who are brought out by different Republican activists who are trying to set us back 1,000 years. And those people don't know what they're talking about. You know what you're talking about. You know the truth. So speak to those people, go to their offices, send them emails and let them know, if you need to know what this is and why we need this, I'm willing to have that conversation with you so that we can protect our children who are also having anal sex. Thank you so much, and have, well, our children who become adults, and you know what I mean. Thank you for attending and have a wonderful day.
Way to bring it home, Juan. Thank you to everyone in the United States and the other 30 countries who have joined us. We'll see you next time. Take good care.